Well, hello, my name is Sherry Nash. I'm the nurse manager of the neuroscience unit at Sacred Heart, and I'm helping with some of the telestroke training. We're very happy to be here. This is Danny Lorden, and Danny's helping us with this. We're going to start you off on a short little video to show you our stroke processes. We'll get it playing here for you. It's only 3.5 minutes. It kind of gives you an overview of the whole program, and then we'll talk about each section individually.
The way the telestroke program here at Sacred Heart works is that we are trying to bring the benefits of having a stroke neurologist out to each one of our smaller hospitals, rather than having the difficulties of having a neurologist at each hospital 24/7, which is difficult for each one of those hospitals to try and get that kind of specialist in each region. Mr. Smith is having the symptoms of a stroke. His family can take him to his home hospital, and he can be seen by his own doctor. And his doctor can call in one of our specialists right there in the room, and together they can be part of a team taking care of Mr. Smith at the moment he is having a stroke. There won't be a time delay, and there won't be the difficulty of having Mr. Smith's home doctor try and describe the subtleties of what is going on over a telephone. We can see the patient, we can see Mr. Smith's eyelashes, we can zoom in that closely. With the help of Mr. Smith's doctors and the nurses at the bedside, we can get more of a sense of the quality of the weakness and the way his eyes move. I can pull up the MRIs if there are those, but most importantly the CAT scan, which is the key to all of the decisions that we make with TPA. TPA is a medication that's primarily given through a vein that goes in through the bloodstream and attacks the blood clots that are sitting in the arteries, blocking blood flow to a part of the brain. Our partner hospitals in the community already do a wonderful job of getting TPA in a swift fashion. Our whole goal is to get more TPA to the right patients in the right time. I think where telestroke is going to benefit is twofold. It's going to be the tricky patients who aren't quite as obvious for stroke, who can get the intravenous TPA, who might have fallen outside of the traditional presentations, and it's going to be the patients who are outside of the intravenous TPA windows, but who could still benefit from an endovascular treatment. Really, it's like I'm right there in the room. I can see whatever the doctors and nurses are seeing. We can be part of that interaction, and that's really where telestroke gives us the benefit. It enriches the entire experience, and it brings those subtle details all together with all of us.
So I'm Danny Lorden. I'm the Regional Account Manager for In Touch Health, and maybe I'll just plug this in real quick. So we had a physician that is able to beam into the patient's bedside in relatively short amount of time. So this is all about getting the right care to the right patient in the right time. So the physicians will be on call for telestroke 24/7, and when Lourdes Hospital initiates a code stroke and needs a stroke neurologist on board, all they have to do is go to their computer, and the nurse can have this at the bedside, or the physician can actually drive it to the bedside, and the physician can beam in and do their consultation. So as you saw in the video, once the physician's connected, their face is on the screen, their name is underneath, so the physicians and nurses and the family know who they're talking to here, and they can begin the assessment. So this device is a mobile device. It has the ability to go throughout the hospital. So we might be seeing stroke patients in the emergency room. We might be seeing in-house strokes. And soon we'll be doing hospitalist services as well. And that might be taking place anywhere in the hospital. So this device works wirelessly on the hospital's wireless network, anywhere we have coverage, and the physician can basically beam in, check in at the nurse's station, and follow the nurse or the physician to the patient's bedside. So once we're basically parked at the foot of the bed, the physician then has the ability to control the camera and the microphones, and they can zoom in and they can examine the patient at very close range. Excuse me. So they might be introducing themselves, so the patient and the family are probably wondering what's going on with a robot wandering into the room. So pardon me, the staff will introduce it to the patient and let them know that we have a stroke neurologist in this case that won't physically be here, but they'll be here virtually with us, and they'll be able to work with us, examine you, look at your CAT scans, just as if they were in the room with us at that point. So they have the ability to zoom in, look at the monitors, look at the patient, interact with the nurses and the physicians and the family just like they were there in person. So they have that ability. They also have the ability to start downloading the patient CT images. So as we know, a stroke patient, the first thing that we need to do with those patients is look at their CT scan to determine what kind of a stroke we might be dealing with, whether it's an ischemic stroke or a hemorrhagic stroke. But by looking at that CT scan, that helps us identify what we're dealing with and whether or not that patient might be a candidate for TPA. So the CT image is very vital to that consultation. That's the next thing they'll do. So once we have the robot positioned at the bedside, we work with the nurses and the physicians to begin the assessment, and Sherry will talk a little bit about how that's done. But I just wanted to let you know that we have the ability also, when the physician beams in and introduces themselves, we can turn the volume up and down here so we can hear better, or turn it down if we need to. We also have the ability, with some other clinical devices that are integrated into the robot, to do things like, for hospitalist services, listen to heart and lung sounds. So we have a digital stethoscope here and a headset so that the nurse or the physician at the bedside can hear what the remote physician, the clinician's, hearing at their end. We also have a privacy handset, so if doctor wants to talk to the nurse or the physician at the bedside, they might say, hey, would you pick up the handset? So let's say this patient is experiencing a bad hemorrhagic bleed, and it doesn't make a lot of sense to put him in a helicopter and subject him to trauma and a great expense when there isn't a lot we might be able to do by transporting him elsewhere. They might want to have a private conversation. Or we might say, let's wander out to the nurse's station and chat out there for a minute, and we'll be back in a minute. So we have that ability. We also have the ability to plug in other clinical peripherals. So although we're starting with stroke, we can plug in echo machines, ultrasound machines, otoscopes, cameras, and send those live images and feeds to the patient at the far end, wherever they might be. So those are just some of the clinical capabilities. So generally speaking, the nurse can push this to the bedside and have it ready to go once they've called the physician that's going to beam into the bedside, or they can go ahead and push it to the bedside and have it ready to go. At that point, the physician can beam in and start doing their assessment. So very, very easy to operate. It doesn't take a lot of know-how about how to get it there, operate it. There isn't a lot to it as far as the nurses and the physicians are concerned. They basically need to push it to the bedside, introduce it to the patient, and then assist the physician with the consultation. In the case where we might get fluids on the robot, we can just go ahead and wipe it down with regular Sani wipes, but we want to be careful about using things like screen cleaners and lens cleaners up here for those kinds of things. This device is on 24/7. It's always on, connected to the hospital's network, and it's plugged in and charged up, ready to go, so that when a stroke patient presents in the hospital, we don't have to worry about whether or not it's charged up, connected to the network, and ready to go. So generally speaking, there'll be a screensaver on here that has the transfer center number that we use to activate the code stroke, and that's the phone number that we call from the hospital here to request a neuroconsult for a stroke patient. So that's about as much as we need to know about how to operate the robot.
Notebook that has your name on it, and in it is our protocols, order sets, lots of helpful information that you can take to use or not use. It does have our my education program in there as well, so that's available to you. I also brought a copy of our stroke packet. It's kind of helpful if you have a stroke patient come in, where you have all of your teaching, your emergency orders, your TPA orders, your other admission orders are all in one place. So they can just, if you think you have a stroke, grab the packet and go for it. It's there only as a resource for you. You are not obligated to use it in any ways. Let's go ahead and talk about the processes. Let's see if I can get this to work. Okay. TPA has been around for a long time. Actually, 1996 is when it first came out. We've learned a lot in that 14 years. There's been a lot of patients that have been treated with TPA. It's a new age in stroke care. We have expanded windows of how long we have to use TPA. It used to be we only could use it up to 3 hours of stroke onset. Now we can go out to 4.5 hours on certain patients. We've had great research to show us successes. We do a lot more catheter-based therapies now, not just IV TPA, but using endovascular procedures as well, and we'll go through some of those and what some of those look like a little later in the presentation. And it's not uncommon to have multiple catheter-based care therapies in stroke care. You may have IV TPA and use endovascular procedures as well for stroke care. Benefits of stroke care, of telestroke, we have the stroke neurologists. Our stroke neurologists on our team do this every day. And for Sacred Heart, for example, we see on an average about 650 stroke patients a year. So we have a very large volume. We do a lot of it, and they have some great tips and tricks on assessments and varying types of presentations. This is just a picture of a CAT scan with an infarct. We do use TPA. That's really the only drug right now available for stroke care. The dosage for TPA, you give it 90 milligrams is your maximum, but it's all weight-based, based on a bolus dose of 0.09 milligrams per kilogram, and then an infusion over the remainder of the 60 minutes. Don't worry if you haven't given TPA in a while and you need to. Our stroke neurologists are there to help you with the dosages and how to mix it, and all of that is available for you. As far as stroke assessment, at the time that you've decided this patient has had a stroke, you've already done your mini stroke assessment, but you're looking at what their face, is it equal? They're looking at your arms, is there a drift? Their speech, is it clear? And if you have any concerns about any of those, it's the time to call. This is the number that we would call. This is our transfer center number. This is a one call, that's all phone number, and this will initiate, as soon as you make this call and say, this is Lourdes and we have a code stroke or a telestroke, however your facility wants to name it, that would be important to name your processes. That helps us with pushing the CTs to the right place, that we know it's a acute stroke and you need some intervention. Mm-hmm. So that will have to be decided here for you. They call the number that behind the scenes will then activate our neurohospitalists who are on call 24/7, and they will be geared up knowing that they have a stroke patient coming from your facility, and will need to be looking for those images, CT images, and then be able to beam into your facility to work with your doctors and your nurses. These are just some of the faces you may see. You won't know who's on call when you access telestroke. It could be any one of our 4 from Sacred Heart, or it could be some of our 9 doctors who partner with us from Oregon. You may recognize some of these names as neurologists that are well known in neural research and in stroke and in MINS criteria. This is our acute stroke algorithm, and there are copies of it available both on the table and here. Basically, you recognize your patients, kind of the process that Denny and I just outlined. You acknowledge that your patient's had a stroke, or you think they might, then you make the call. The trigger point is knowing that a stroke patient is less than 6 hours of onset, so it's real important to know when they were last seen normal. That 6-hour trigger is the kind of the window of what we can or won't be able to do for your patient. Then it's the usual emergency department or in-house processes for line them, lab them, and get them to CT. And at that point, you would have made that initial call. They're coming back from CT. Someone will need to bring the robot to the patient's bedside, position it at the bedside, and then the stroke neurologist will ask the nurses or the physicians to help them with the assessment, and he'll be interacting with your patient and your physician group. Denny already talked about the 2 different types. The RP7 is what you have here. The CT versus CT angio. most places will have a protocol in place where they'll do the CT first, and if there's no hemorrhage, they automatically go on and do the CT angio. That's very hospital specific in processes and requires approval for moving on to the CTA. Initially, just getting the CT determine whether it is hemorrhagic or not, that's the trigger point. If a CT angio is done, that's added information that we can use if an endovascular treatment is possible for your patient. If not, that's okay. We can get initial CT. We'll probably do an angio before they go into intervention if that's the plan. This is the NIH stroke scale. Many places have their nurses trained in NIH stroke scale, either in the emergency department or on rapid response. At Sacred Heart, we have our rapid response nurses, our neuro nurses, and all of our ED nurses are trained in the NIH. The NIH can be accessed through the American Heart Association website. It's also, I've heard recently that they have started to charge for that. I don't know because I haven't been on myself recently. But you can also Google it, NIH stroke scale, and there are free sites that are out there that will help you get the training that you need. The robot doesn't have arms, so the neuro hospitals may ask you to help them with the visual testing that's done at the bedside as part of the NIH stroke scale. The best way to do that would be to either have the patient cover their one eye if they can, or you do it if they have deficits. And then you're going to put your fingers, using different fingers in each of the quadrants, have your patient describe to you, how many fingers do I have here, how many here, how many here, how many here. That, and do the same thing for both eyes. That helps the neurologist be able to see if there's a visual field cut. Helps us determine where the stroke is in the brain. Sensation is the same. Many times I will use a straightened paper clip to start with the face. Does this feel the same as this side? Does this feel the same as this side? Using face, arms, and legs. That helps with the sensation to be able to determine whether there's some paresis in one side of the body or the other. Neglect, often the nurse at the bedside will be the one that notices the neglect first. As you walk up to your patient and you notice that they're not tracking at all to one side or the other, that's easily reported to the neurohospitalist and can really help us with where that stroke might be occurring. Bedside swallow, here at Lourdes, I understand there's a say no to PO, pretty much philosophy in the emergency rooms, and if the patient has any drooling or swallowing difficulty, they just automatically get a therapy consult, speech therapy consult. That's great. I've included in this presentation a water-based swallow, bedside swallow. If you choose to use it, you don't have to, but it's there if you would like. Also, there are some myth busting that we need to talk about. As I said, over the years we've learned a lot about TPA, and what we've learned is that there are new treatment opportunities for those patients that have extended out to 4.5 hours. We'll talk about some of the exclusions in just a minute, but as far as inclusion and myth busting, there really is no age limit for treatment of TPA. Patients who are in their 90s often do very well getting TPA. That used to be an exclusion. Patients on Coumadin can also receive TPA depending on what their INR is. Patients with a low NIH stroke scale can receive TPA. It used to be those patients in a low NIH 4 or less just had some speech difficulty, were thought that they wouldn't benefit from TPA, and more recent research has shown that they can do very well. Rapidly improving symptoms can also receive TPA, and those patients who are hypertensive can also receive TPA. We do control their blood pressure initially, keeping it less than 180 systolic, using often labetalol or Cardine, and I understand both of those are formulary for you. Works very well. As in stroke care, as we're further out, blood pressure is rising, is probably the brain's way of reperfusing, and we allow higher blood pressures after the TPA. This is just our telestroke network documentation. It helps everybody keep on track as far as timelines, how soon when we're looking at, as partners for us, you are get with the guidelines through the Stroke Association, American Heart Association, and we'll be reporting your data as to your door to CT time, your door to MD, your door to drug. All of this particular form is a good way to document that as you go along, rather than have to dig through the materials, your charts, to find all that information. It's here for you if you'd like it. Stroke treatments with As we said, with TPA, there is the expanded treatment out to 4.5 hours, but there are additional warnings for that 3 to 4.5 hour window. Those are those patients who are older than 80. And again, this is the 3 to 4.5 hour window, so expanded window time frame. Greater than 80, all patients receiving oral anticoagulation, regardless of their INR, and an NIH stroke scale greater than 25, and a history of a previous stroke or diabetes. Any of those things would exclude your patient from being a candidate for TPA in that 3 to 4.5 hour window. There, in the materials that I brought for you in our protocols on the back of our Alteplase orders, there is the inclusion-exclusion criteria as well as the expanded criteria, and also that same document shows you at which of those patients might be excluded from IV TPA, but they still might be a candidate for intra-arterial TPA. These are some of the endovascular procedures that can be offered your patients. This is the Mercy retrieval system. Again, this is an endovascular procedure. This is essentially a corkscrew device that we enter through the groin, catheter up into the cerebral arteries, get up to the clot, can actually corkscrew through the clot, and then we can actually pull the clot out. This is a penumbra device, and it's a technology where we use both going through the clot, and then there's that clear tube there is a suction tube that can actually suck the clot into the tube. And the solitaire device is a combination of the other two, but it also has a small little umbrella distally that prevents any of those tiny clot fragments from going distally, and also allows us to be able to pull the clot out.